depiction of, so this is a depiction of the microscopic histologic changes seen, and you can see in A that there is extensive mucosal necrosis and intramural hemorrhage, which is shown by the asterisks. And here in the submucosa region, you can see edema and also paucity of cell infiltrates. That means you don't see any neutrophils. So in the neck, the number of neutrophils seen is quite low, hence the name neutropenic enterocolitis. So you can also see some necrotic glands in the colon and some congested vessels as well. Okay, so this is how the histology looks. Clinical manifestations of neck is usually in the terminal ileum and the cecum, and the cecum is favorable because it's quite distensible and relatively there is less vascularization compared to the colon, and that's why the ileocecal region is commonly involved. And most patients complain of a right lower quadrant pain, which can mimic also appendicitis. And so 90% of that time abdominal pain is present, and fever about 84%, and the diarrhea in some papers about 72%. So less common symptoms are constipation, nausea, and vomiting. The complications associated with neck is bacteremia, fungemia, and a septic shock. These are especially septic shock. Most patients, once they develop septic shock, the prognosis is quite poor. Local complications include intestinal perforation, peritonitis, abscess, and sometimes fistulation. In the gastrointestinal bleeding, which could be secondary to the development of disseminated intravascular coagulation, which is associated with sepsis as well. So other complications, as mentioned, pancytopenia and DIC, electrolyte imbalance, hyponatremia, hypokalemia, hypophosphatemia, hypoalbuminemia, and these are major complications which have to be corrected. If we look at the pathogens involved, 60% are Enterobacteriaceae. So this is including Escherichia coli, Klebsiella species, and Enterobacter coliaceae, and about 25% gram-positive cocci, Enterococci, Staphylococci, and Streptococci, 6% Pseudomonas, and 5% anaerobes. Okay, so sometimes you may have cutaneous necrotic lesions associated, which could indicate myonecrosis. So another issue is fungemia, and fungemia can account for about 6% of patients, and the type of fungus is Candida species, about 76 to 94%. Times there are reports, a growing number of reports of aspergillosis, and now recently there are also reports of mucormycosis being implicated as a cause of fungemia. Imaging abdominal plain films can help to identify air, free air, and also sometimes pneumatosis intestinalis. But the best imaging modalities are ultrasound and CT abdomen. So intestinal wall should be greater than 4 millimeters. And there are all studies that also have a bit older studies that say the risk of perforation, leaking into the peritoneum, or air within the peritoneum can occur because if the thickness is about 10 millimeters and above, and surgical consultation is required in such scenarios. So the benefit of having an ultrasound is you don't need to inject any contrast. and the risk of radiation is low. And for unstable patients, especially children, you can bring the ultrasound machine and do an ultrasound at the bedside. And of course, the cost in our scenario is quite lower than doing a CT. However, CT is more accurate, and it excludes other differential diagnoses. And by doing a CT, you can also pick complications quite earlier. So the standard reference is CT imaging. So here's a plain abdominal film to show the arrows show the development of pneumatosis intestinalis of the right ascending colon. Here is the cecum. You can see marked circumferential cecal and ascending colon thickening, and with mild pericolonic inflammatory stranding, the small arrows here. This is an ultrasound to show the thickness of the wall of the cecum, and there could be usually hypoechogenic, but at times there could be cecal fat being hyperechogenic. So going into the investigations, some have tried to make major and minor criteria to make a diagnosis of neutropenic enterocolitis. And the major criteria I've already mentioned, but looking at the minor criteria, you see severe abdominal pain, abdominal distension, abdominal cramps, diarrhea, and lower GI bleeding. In these investigations are encouraged to rule out other causes of colitis. And in those undergoing transplant, especially acute GVHD GI, it can be sometimes confusing to differentiate between neutropenic enterocolitis. So there are some reports that NE or neutropenic enterocolitis can occur mainly before engraftment, and after engraftment, acute GVHD GI is more likely. But you can also have isolated GI involvement is quite difficult to differentiate. There are some pathologic reports where they say apoptosis is less common in neutropenic enterocolitis. And there could also be, these things can also overlap with neutropenic enterocolitis. So it's worthwhile doing especially toxogenic Clostridium difficile workup for toxins A and B to identify Clostridium difficile, which should be treated quite aggressively. You may use this. Sometimes there are some confusion between infectious colitis. Doing a stool exam, stool culture will also help to differentiate. But sometimes you can also have Clostridium superimposed infection with neutropenic enterocolitis. So it's quite difficult to differentiate in the scenario where neutropenia is involved. Differential diagnosis of abdominal pain in neutropenic patients, CMV colitis, Clostridium difficile colitis, leukemic infiltrates of the bowel, GVHD involving the gut, ischemic colitis, cholangitis, cholecystitis, acute appendicitis, bowel obstruction, and autoimmune colitis, the use of checkpoint inhibitors. So I think checkpoint inhibitors are less rarely used in our scenario, but it should be included in the history. There have been some reports. One report in West Africa where necrotizing enterocolitis was missed, and they went in and thought this was appendicitis, and later the patient died, and the intra-op finding was not suggestive of acute appendicitis. So this is very important to know about that. The iliocecal region is one common site of for the most commonest site for a neutropenic enterocolitis. Another important point before I go into the management is sometimes you may have clinical and also radiological evidence for the diagnosis of neutropenic enterocolitis, but there are reports that show that in 15% of cases, these patients may not have any histology suggestive of that. And the reverse also applies where you had the discrepancy between pathology and clinical findings, where in 26% of cases that had suggestive histology of NE were initially clinically not suggestive of neutropenic enterocolitis. So keep that in mind that there could be discrepancy between clinical findings. Once the patient has been identified to have a neutropenic enterocolitis. Hello, can you hear me?
Yes, you just went away for a second. You're back.
Yeah, okay. So another important thing to look into is platelet count. DIC is a scenario where patients could bleed, and our aim is usually to make the platelets above 50 and fibrinogen levels above 1.5, and INR above 40% from its baseline. There are some discrepancies between the use of controversies between the use of GCSF, but especially in patients who've survived one episode of neutropenic enterocolitis, they will develop another episode. So especially after chemotherapy. So keep that in mind when you manage these patients. You have to look into the history and the scenario they had passed through was the previous cycle or chemotherapy, and giving GCSF helps, especially with preventing primary neutropenia, and you might be tempted to give more GCSF prior to chemotherapies to shorten the period of severe neutropenia. So very important is medical management. You can do a lot to help, and I'll discuss that in detail. With the medical management, the first thing you have to, some call this nothing pearls or nil PO. So oral intake should be stopped, and you should decompress the gut by inserting an NG tube and sucking out and intestinal contents. So this helps to prevent leakage in the peritoneum or any perforation. Broad spectrum antibiotics, primarily in textbook countries or in developed countries, the tazobactam, piperacillin tazobactam is one of the first line antibiotics considered, especially for the coverage of gram negatives. And the cefepime can be used in our scenario. And second line carbapenems can also be used, especially in ESBL scenario. Carbapenems can be very useful. And if patients are quite critical, especially for gram positives, the introduction of vancomycin or other related antibiotics should be considered. So IV fluid and electrolytes, but especially in sepsis where they could be hypotensive, and the previously mentioned electrolyte imbalance should be corrected. Blood and blood products should be given FFP, fresh frozen plasma, platelets, packed RBC, and if there's bleeding, especially profuse bleeding, then the whole blood. Vasopressors are indicated in the scenario of hypotension. So this is what the empirical treatment should be considered. And glycopeptides are very important for gram-positive cocci. And usually if the patient is septic, having derangement, vital signs, or a change in sensorium, one should not hesitate to start these patients on glycopeptides. Fungal, there's no clear consensus when to introduce antifungals. One review said after fever, if fever persists more than 72 hours. In the WHO recommendation, the latest 2023 for febrile neutropenia, their recommendation is that after 96 hours to give antifungals. But if a patient is his condition is not responding within 72 hours, then
No, you're not Dr. Tani.
So can you hear me? Sorry.
Daniel, you
No,
just went
okay.
away for a while. You started talking about complications.
Okay. So you lost me way back. So what did you hear last? Sorry.
So you can go forward. You would after this one, yeah. After this one, yeah, yes, yeah. Go back.
Okay.
You were talking about the slide, and then you faded away.
Okay, sorry about that. I hope you can hear me now. Most treatment in neutropenic enterocolitis involves medical management, and one should refrain from promoting oral intake. And then the preferable thing is to keep them nil per os and immediately decompress the gut by inserting an NG tube and also removing intestinal contents. This prevents leakage into the peritoneum or any risk of perforation. So broad spectrum antibiotics are recommended, which I will discuss on the next slide. IV fluids, especially if patient is hypotensive or in shock, then, and also electrolytes, KCl, normal saline, and if albumin is available, also giving 5% or 25% albumin might help. And blood and blood product transfusion is vital because these patients end up developing DIC and correcting the platelet count above 50,000 and fibrinogen about 1.5, and also giving FFP to correct any the process of DIC, that it will be helpful. So vasopressors are recommended if there's a hypotension or any shock, septic shock scenarios to help. So antibiotics, can you hear me now? Hello?
Yes, Daniel, you can.
Yes.
Okay. So gram-negative bacilli are the most implicated, and if available, piperacillin and tazobactam would be preferable because it has a broad spectrum. Cefepime is another important drug which is effective against Pseudomonas species. So ceftazidime in our center is becoming has bug been resistant to ceftazidime. I don't know, but the most important thing is to follow your resistance pattern and treat accordingly. So and also involve infectious disease on the choice of antibiotics. And ESBL patients or bugs, carbapenems are preferable. And if patients are having a severe scenario where they have change in derangement
Hello, I think we lost you again.
Yeah, I think he's struggling with the internet. It's a bit unstable. Let's just wait. He will be back. Daniel just joined again, everybody, so he'll be back.
I think, yeah, he's back now.
So apologies for that.
No problem.
Can you see my slide?
No, we can't see your slides at the moment.
I think not. Can you see it now?
We can see. Yes.
So apologies for that. I think we're stuck on this slide. Am I right?
Yes.
Yes.
Okay, so I'll try to be quick here. Most important is gram-negative bacilli are the implicated, especially Pseudomonas species and Enterobacteriaceae. And preferable broad spectrum gram-negative coverage will be papiracillin with tazobactam. Among the cephalosporins, cefepime is quite active and has good Pseudomonas coverage. Anaerobes can be associated, and the use of metronidazole, especially or ornidazole, especially if you have superimposed Clostridium difficile infection. Oral metronidazole is quite preferable in meeting its target. If the patient does not tolerate oral metronidazole, then one would go for intravenous form. So critical patients, patients with deranged vital signs and change in sensorium, one should also consider a gram-positive cocci. And the initiation of antibiotics should be within the first hour. So don't wait to take a blood culture or other investigations, but try to start antibiotics within the first hour, which is associated with a good prognosis. So among the glycopeptides, vancomycin, teicoplanin, and vancomycin seems to be available in sub-Saharan Africa. Linezolid may also be available. So another thing about gram-negatives, these could have resistance, ESBL resistance, where carbapenems play a role also. Carbapenems like meropenem also have anaerobic coverage, and that has a benefit when you're treating neutropenic enterocolitis. So another important point is when to introduce antifungals, and that is according to the 2023 WHO recommendation of antifungals in febrile neutropenia, the recommendation is to give after 96 hours. But in patients which are critical and not doing or not responding well to antibiotic coverage, you can start as early as 72 hours. So the preferable type of antifungal will be echinocandins, caspofungin, and fluconazole can also be used, but there is a growing number of candidal species which are resistant to fluconazole. So voriconazole could be another alternative. So I just a few words about neutropenic diet, and in this study where they checked for all English publications from the year 2000, they looked at about 340 scientific articles were identified, and they eventually ended up with only 9 studies, and they showed that there wasn't still great variation in the criteria for indicating the use of neutropenic diet, and when to start it and when to discontinue it, and even the difference in composition. So there was no consensus on the type of neutropenic diet to introduce in such a scenario. So the conclusion was, in the absence of guidelines that standardize the use of neutropenic diet, and because of heterogeneous approaches, the available literature presents an absence of evidence on the use and viability and effectiveness of neutropenic diets in oncologic children with neutropenia. So I think across the world, I think this is being well accepted, and the role of neutropenic diet is kind of dwindling. When we come to the framework, according to Vianney K, actually this Vianney K is Brazilian, but there are some studies as well from India with similar findings. And depending on, so when do we introduce the type of feeding in pediatric oncology includes oral feeding, enteral tube feeding, and total parenteral nutrition, and also peripheral parenteral nutrition. But in neutropenic enterocolitis, in best centers, because of the risk of oral and enteral feeding resulting in perforation or peritonitis or other complications, TPN is directly started. So this, we don't have the luxury for TPN, and the challenge is what to give. So what do you give when you have a child who has a gut thickening of about 8 millimeters, the vomiting, critically sick, and is losing weight more than 5%, or is crossing the 2 percentiles and developing severe acute malnutrition. So the recommendations given here is to keep them in NPO and give essential amino acids, and this can be combined with dextrose and electrolytes. And that means you have to check the electrolytes quite frequently, and also check also the sugar levels in such patients. And how effective this is, really no one knows, because no studies have been done. And in our scenario, we've placed children on dextrose with normal saline, and also given added electrolytes, KCl, to battle the derangement, depending on if they have other electrolyte imbalances. Once in a while, we might get 5% albumin in patients who have very low albumin levels, and the challenges are quite high. So eventually, as the GI symptoms start to disappear and the absolute neutrophil count increases, then you can resume liquids, start them on a liquid diet, and then eventually introduce oral diet, which, if the patient tolerates, you can challenge with high energy and high protein diets. So this is the challenge we have. Just a few words on peripheral parenteral nutrition and central. In the PPN, you can only use it for a maximum of 2 weeks, whereas in central access, you can use it longer. And the issue of dextrose is limited in PPN, but in central, you can go up to 20%. So TPN is introduced in a scenario where you feel that the nutritional support may not be met, and the duration is beyond 5 or 7 days, then you have to start patients on TPN, which should be looked into. So this can develop into a study and look at ways of supplementing patients who have neutropenic enterocolitis. So again, monitoring random blood sugar, serum electrolytes, liver function test, renal function test. And if you have TPN, then you have to also check for risk of hyperglycemia and hypertriglyceridemia. These should also be looked in. The status of the liver, cholestasis can develop, and gallbladder changes can also be included. So the persistence of abdominal pain, you should do liver function tests, and also ultrasound to check the status of the liver and the gallbladder. And the risk of infection is also quite high when you have lines placed in for a longer time. The risk of infections are also increased. So final words on the indication for clinical intervention. Persistent GI bleeding despite resolution of thrombocytopenia and coagulation defects. If there is any evidence of intestinal perforation or sepsis or hypotension, then these are indications for surgery. So to summarize, clinical diagnosis of NEC includes fever, abdominal pain, major evidence of intestinal wall thickening. The prevalence of NEC is variable, and prolonged and profound neutropenia and altered microbiota dysbiosis play a significant role in pathophysiology of NEC. Ultrasound imaging is an efficient and safe, cost-effective means to make a diagnosis and for follow-up. And management of NEC involves early detection, bowel arrest, broad-spectrum antibiotics, correction of electrolytes, transfusion of blood products, and optimum nutrition support and surgery. So thank you for listening. I'm open for any questions. I hope you didn't go to sleep.
Thank you. It was a great presentation.
Yeah.
We will take up questions.
So any questions?
Thank you so much, Daniel. Judy, I just wanted to know, by any chance, do you know how long your children usually have to be on the IV fluids? You don't have access to TPN. Is it usually severe cases, or are you able to feed the fluids?
Thank you for that question. Can you hear me?
Yes.
Okay. So the most critical types are those who've been on treatment for AML, and those patients tend to crash. And usually are critical, and you have no opportunity to start any oral or liquid diet. But we have had patients like treated for solid tumors, even ALL patients, high-risk ALL patients, who have had symptoms of abdominal pain, fever, responded to treatment, but still have bowel thickening. And that means the bowel thickening has not improved, but the other symptoms have improved. So there's no tenderness, no abdominal pain, but just imaging showing bowel thickening. And we've been tempted in those patients to introduce liquid diets. And most of these patients have responded well, tolerating liquid diets and semi-solid diets, and eventually placed on a solid diet without significant decrement in the size of the thickening. So, with these patients, our observations are the most important thing is the count coming up. So we've had patients improving, the counts improving, and the symptoms improving, and no physical evidence of severity. And bowel sounds normal, active, but imaging still like 6 or even 8 millimeters. And we've in these patients, we've seen that the symptomatic improvement with the improvement in neutropenia is what really matters in introducing oral intake. So these are just observations. We haven't done any studies, but this is something to look into.
Thank you so much. There was a question from Yatunda. I hope I pronounced your name right. You can just ask Dr. Daniel?
Okay, thank you, Dr. Daniel, for... Can you hear me, please?
Yeah, yes, I can hear you.
Okay, thank you so much for the presentation. For the uncomplicated cases, no perforation, and how soon do they respond to medical management when we start treatment? For example, how many days do we expect to start seeing improvement as we see the WBC count increase? Is there any suggestion to that? Thank you.
Sorry if I've understood your question. Are you talking about the change in antibiotics or discontinuation of antibiotics, or is that it?
Okay. No. I'm asking, how soon after commencement of medical treatment do we expect to start seeing them improve if there is no complications? Hello?
I think he wants to show you on his slides.
Okay.
Thank you for that question. Usually, if treatment is started earlier, within the hour, the outcome of these patients tend to recover quite quickly. And quickly in the sense like 5 days, some 3 days, show some improvement by 72 hours, and by 5 days they might improve. So it's all about your timing of your introducing antibiotics in care. But most of the time, these patients may be waiting for a bed, or may be picked late, and when they come in, they're really complicated. And especially AML patients, we usually keep them on the floor and expect follow the signs of pain. So the most important point is having a high index of suspicion. If patients have abdominal pain, I would do an ultrasound quite quickly to rule in or rule out neutropenic enterocolitis. So pain is initial manifestation, and if you've seen about 94% of these patients had abdominal pain. So fever could be febrile neutropenia, unless and usually if the only presentation is fever, it might be missed unless they have vomiting or other symptoms suggestive of abdominal complaint, they might be missed.
Okay, thank you.
Did I respond to your question?
Yes, you did. Thank you.
Thank you.
Daniel, I have two questions. First is, what is your take on giving an early TPN, or total parenteral nutrition, like much early when the NEC is in the suspected stage, and when we know that the counts are decreasing, and like you mentioned, though the suspected abdominal pain and all those kind of complications, they are setting in. So how early to start the TPN?
So TPN is a clinical, starting TPN is a clinical decision. What the ultrasound, you have to have the complete scenario to say this is neutropenic enterocolitis. If you don't have bowel thickening and you have abdominal pain, it could be something else related to your chemotherapy, and you have to rule out other conditions. But if you have something like 4 millimeters and above, then it would be wise to keep NPO and also look at the neutropenia. The timing, usually neutropenic enterocolitis occurs 10 to 14 days after intensified chemotherapy. So usually before that, neutropenic enterocolitis won't be commonly seen. I'm not saying it won't be seen, but it won't be commonly seen. What you would be considering will be febrile neutropenia. And at that point, you will be treating aggressively with antibiotics and continuously assessing these patients. So in case you have, so doing a thorough physical examination is very important. If there is any tenderness, abdominal tenderness, then one should, even if there's no complaint of abdominal pain, one should do an ultrasound and confirm. So usually you're looking at about 10 to 14 days after the intensified treatment to identify neutropenic enterocolitis. Before, other complications could be associated. The patient may have pneumonia, may have sepsis or febrile neutropenia for that matter, or even hospital-acquired infection. So once you make the diagnosis of neutropenic enterocolitis, your anticipation is that this patient would need supportive care for more than a week. So most physicians would, with the team, would decide to start on TPN and giving central and continuing that way. So you have to make the diagnosis to start the TPN.
Okay.
Thank you.
And thank you, Daniel. And my second question is, what do you think of using probiotics in NEC? We clearly don't have much data to support that, but what do you feel?
I've seen a number of, especially in India, I did a 6 months rotation in Tata, and they were using a lot of probiotics for patients who had a microbiota culture resistant scenario where they would, before initiating on chemotherapy, they would do a stool exam and check whether these the flora was in the gut based on the stool culture would be resistant to whatever available antibiotics. And honestly, I haven't come across any evidence for that. I haven't come across whether that will improve the microbiota or not, because in a neutropenic enterocolitis, the first thing you'll do is keep them NPO, nil for paros, and there won't be any oral intake, and you would want to decompress the gut as quickly as possible. So even the order for NPO would have an effect on the gut microbiota. Usually anaerobes are present in a normal flora, but now you will have facultative anaerobes, which proteobacterium and bacilli taking over the gut flora. So I honestly don't know whether that has any benefit or not.
Okay. Thank you so much.
Sorry about that. I didn't complete that answer.
I'm so sorry.
I can't hear you.
Yes, yes.
Any other questions? No, it seems like there's no other questions. Raju, you can just finish up. Daniel, thank you so much. I just wanted to say I've got a lot of messages of people asking, are we recording this? It's just the time that was troubling them. So thank you so much for doing this.
Thank you, Judy, for the invitation to present this educational session. Sorry for the interruption. It's a challenge in this part of the world. Thank you.
Thank you, everyone.
Thank you. Hi. Thank you, everyone. Have a good day, afternoon, evening. Bye-bye.
Bye. Thank you.
Thank you. Stay safe.
Bye. Bye, everyone.
Bye, Daniel. Thank you.
Bye.